BioBalance Healthcast, episode 128, 5 health issues that doctors often miss.
BioBalance Healthcast features conversations about positive aging. Your hosts are Dr. Kathy Maupin, Medical Director of BioBalance Health and a leading expert in treating symptoms of aging, and Brett Newcomb, a licensed professional counselor.
So we're going to continue our conversation about 5 sneaky health issues that doctors often miss, but should be on your radar personally as a consumer. We spent a lot of time last time talking about sleep apnea and sleep and fatigue related issues, and we ended it by talking about the trigger for that is the loss of testosterone. So today we're gonna pick up at that point, talking about hormone changes in a woman's life, in particular, what we call testosterone deficiency, which is often called menopause. Perimenopause.
Which means, that word means around menopause, but this happens 10 years before menopause usually.
Okay.
So we talk about testosterone deficiency starting around 40, and menopause average age is 51.
Okay.
So there's a big space. So I don't think that's why we named it testosterone deficiency. They call it perimenopause.
But and there are a couple reasons why the ages matter.
Right.
And one is that, and we've done a podcast on this, and you can, if you look at the list on the website, you can find it. There have been increasing statistical occurrences of women over 40 having cardiovascular diseases and dying from heart attacks and strokes. And the numbers are going up. And that correlates to the testosterone deficiency.
Yes.
So there's always a question in science, is a correlation also causative? And we contend that in this case it is. So when you look at cardiovascular risk and testosterone loss, please be aware of that, because that's where, when you get into perimenopause, one of the things that may happen is you may start to have some heart-related issues.
And the way you see it is after 40, you often see that your weight goes up, your cholesterol goes up, your triglycerides go up. So you see it on your lab work, and everybody's like, well, why did that happen now? It's supposed to happen after menopause, which is 10 years away.
Right.
And generally it happens because the first thing that happens in aging is testosterone drops. So that all starts happening, and then that allows, and inflammation goes up, CRP goes up.
Yes.
So then you start collecting, I call it goo, but plaque on your vessels, and that leads to heart disease.
And so the research is saying that the optimal time to intervene to prevent that, if you're concerned about preventative medicine, is within that first 10 years. So we're talking about from 40 to 50, and the onset of menopause for most women is 50, 51. So
Long
in that
before
first
you need
10-year
estrogen.
window, when it begins to break down, is the best time to intervene. Now, you can intervene later, and you can have positive gain later, but you are still at risk if you don't intervene.
And then after menopause, then they've finally written it down in a lot of different places. After menopause, the 10 years from the time you start menopause on, you should replace your estrogen, because women who do have a much lower risk of stroke, heart disease, and dementia. So
who would have thought?
Who would have thought? I mean, 10 years ago they told us it was just so terrible, and now they're coming back and going, I don't think that's right, because now all the studies show it prevents all these other diseases. And now that we live a long time, we should think about those other diseases. So it keeps us healthy, it keeps our metabolism going, and both testosterone and estrogen help us repair cells, it stimulates our growth hormones, stimulates a lot of other hormones. So we need to replace them when they're gone.
But we need to replace them in the appropriate way. There are lots of ways, for instance, that you can replace your testosterone. Some are more site-specific and intervention-specific, and some are more global in terms of just general overall quality of health.
Right.
How that is administered and delivered is a conversation that you need to have with your doctor based on what you are identifying and what you're trying to treat and respond to. But the piece Kathy's mentioning now, especially for the menopause, is reframing the whole estrogen replacement conversation. And the literature, the research, the physicians who are on the leading edge of this are all screaming, stop, pay attention, that other study was wrong.
that other study was wrong, and now we had thousands before it that said that estrogen replacement was good and healthy, and we had hundreds afterwards.
Yeah.
So now we're trying to catch up and say, the old studies were right.
Yeah.
And anyway, we've had lots of discussions about this, but this conversation is now on Yahoo, which I guess makes it gospel. We've been saying it for a long time, but it really is important to replace hormones that are missing, and that's a conversation you may have with your doctor. Like, say you're 40 to 50, people come to me and say, I have hot flashes, but my estrogen's fine.
Yeah.
And I've been telling people I've had hot flashes, my doctor, and they keep going, oh, you don't have hot flashes, you're far from menopause. Well, hot flashes may be a sign of menopause and loss of estrogen, but they come from your pituitary gland, and it makes several stimulating hormones. It stimulates other glands. So the two that stimulate the ovaries are FSH and LH. When they go up, yes, you do get a hot flash because you don't have any estrogen left. But the other hormones that are being stimulated, if your thyroid isn't working, then your TSH goes up. That can give you hot flashes. Low thyroid, high TSH gives you a hot flash. But what we're talking about is testosterone. Testosterone goes away, and you start getting hot flashes from that. What are you laughing about?
Your enthusiasm and your passion and your knowledge base is impressive. And I'm sitting here thinking about, Kathy Maupin, MD, meaning medical detective. You trace all of these things down with the knowledge that you have. You were telling me about a woman that came in complaining because she was losing her eyesight. She lost her eyesight in one eye.
Well, she didn't complain to me about that because she knew that wasn't my area. But
Right.
in her history,
Yes.
she told me that she had an autoimmune disease, and she had a rare association of an autoimmune disease that caused her to progressively lose her sight. And in the end,
She was getting shots in her eye.
oh yeah, oh my gosh, this darling lady. And so she came to me because she, all kinds of other symptoms,
Right.
okay?
All right.
So she came for all of these testosterone symptoms, but she was also being treated for an autoimmune disorder with very aggressive medication, and her eyes separately by an ophthalmologist who specialized in this at one of the medical schools here. And so she was being taken care of very well, and I looked at it as from a different angle.
Very well by competent doctors who were
With
exercising what we
excellent-
call
I mean,
standard of care.
Experts.
Yes.
Experts who were doing a really good job, but they said, you're going to progressively lose your eyesight.
Yeah.
And so I said to her, it's an autoimmune disorder. I haven't seen this particular manifestation of this autoimmune disorder, but I have seen all the other autoimmune patients that I take care of get better on testosterone. And there's a lot of studies that say that testosterone not taken orally, it can't be taken orally, but non-oral testosterone at a fairly high level, you have to replace it higher than physiologic. But there are no downsides really except facial hair to that. So that's not an issue. And if you can replace the testosterone at a higher level in women who have this issue, then it can stop the progression of their autoimmune disorder. So if you have rheumatoid arthritis and your joints have been progressively destroyed, then it stops there. It doesn't generally go back and replace the joint.
Right.
It doesn't fix it, but it stops the progression of your own immune system attacking your joints. And I told her this information in terms of all the general autoimmune disorders. I said, I can't promise you anything. I've never treated this disorder before.
Right.
But I want you to look and link this together and see how you do over the next 4 months. Well, she came in and told me that she had no more progression, no more shots. And she had, and honestly, she didn't have to progress to the next autoimmune medication, which was had a lot of risks associated with it. So she didn't have to go upscale to another drug from the one that she was on. She stayed on the one she was on, which is great. I don't take people off their medications. But now she stopped progressing. And her doctors were confused. They said, we've never seen this not progress. And I have a lot of studies that don't talk about that particular manifestation, but all the other people I've treated have stopped progressing. I guess I can't say all. 95% of them have stopped progressing.
Yeah, we can't promise you the same results.
Yeah, and we can't promise anyone that, but there are studies in the rheumatology literature about treating testosterone or giving testosterone in a non-oral way, shots or pellets.
And the reason she keeps saying non-oral is if you take it orally, there's a first pass effect in the absorption of the body, you metabolize it, that takes a lot of the significant ingredients out of it.
It makes estrogen, which is not the friend of an autoimmune disorder.
Right.
Some people need a little estrogen, but we offset the estrogen with a lot of testosterone, and that mixture works really well. So I've seen amazing things. I have a patient that has MS, which has now been found, I was trained that it was a virus, and we've now been taught that it's an autoimmune disorder. They finally come up with the real answer to that. And
So go back again before we get into that story,
All right.
and explain what an autoimmune disorder is.
Okay, autoimmune disorders occur more in women than men, and I think, and that some studies say, because our testosterone is lower in general than men's, but and we lose it sooner. So autoimmune disorders happen in our 40s usually, or late 30s, early 40s, or middle 40s. So the timing's right for loss of testosterone. And testosterone's a modulator of the immune system. So if your immune system is attacking your body, which is what autoimmune is, it's attacking yourself, thinking it is a foreign tissue. It's like if you had a bacteria, your body attacks it and it's gone. You've been cured by your own body. That's what your immune system does. When the modulation goes away, then it overreacts and it attacks your own body, thinking it's a foreign piece of tissue, and it wants to kill it. So it goes to your joints in rheumatoid arthritis, it goes to your kidneys and your blood vessels in lupus, and in MS, it goes to the myelin that covers your nerves. So, and attacks it and kills your own cells.
Kills the protective stuff that your body makes because it needs to use it.
Right, and so the whole idea is they give you medication for autoimmune disorders that just decrease your immune system. And the catch to that is...
So it won't be able to fight.
So it won't be able to fight. So the catch to that is then you can get some
vulnerable to
other
everything
problems.
else. Yeah.
Right, perfect, vulnerable. That's the exact term.
Yeah.
But, and that's what's necessary often to fix or stop progression of these diseases. But what testosterone has in it as its advantages, it's a modulator. It doesn't decrease the immune system so it doesn't work anymore. It just makes it recognize your own tissue better. It stops attacking and overreacting. So you don't become immune compromised and you don't kill off your own cells. So it modulates the whole thing. So it's kind of...
So now tell the story about the gal with MS.
Okay. So I have a patient with MS, and she loved to work out, she loved to run, she loved to do all those things. All the things she loved had been slowly taken away because the MS had gone after vocal cords and everything else. So all the things that she loved to do had been taken away, and she was very, of course, depressed, and as anyone would be. She's lovely and outgoing, and she wanted to get back to the things she loved. And she's in after her first dose of testosterone, and I have to say she's still taking all the medicines that she's supposed to. So nothing's been taken away from her in terms of medical treatment. But after her first dose of testosterone, she's gone to the gym very often, every week. She's not been able to do that before. She's starting to run.
Let me interrupt you again. When
Yes.
you say first dose of testosterone,
Oh, that means
you're talking about
pellets.
the pellets that you insert
Right.
that last for up to 6 months.
Right.
It's not like a shot or an oral dose that you take once a week, and so a week later she can now miraculously do all this.
No, she's gotten better over the last 4 months.
Okay.
And now she can do things that she couldn't do before. So not only has it stopped the progression, but it's actually made her better.
So she's
And-
somewhat rejuvenated. She's able to go to the gym. She can run again.
She hasn't become all better, but she has been able to do things she enjoys, and she
Yes.
hadn't been able to enjoy.
Which is, again, an immeasurably important point that we want to make, because we are all going to age. We're all going to get old. Our bodies are going to break down. We're going to die. The challenge that Kathy posits to all of us is, do you want to live with a better quality of life each and every one of the days that you have? You know, there are so many things that historically we've been afflicted by that cause us to shrink, to become vulnerable, to become immobile, to go and sit in a corner, go to a body storage facility where they just feed and water you, and wait for you to die. And the treatment that Kathy offers and that she passionately expounds in these podcasts and in her book and in her practice says that we believe that you can improve the quality of your life and function in a much more dramatic and capable way for the rest of your life.
My heart goes out to patients that come in and they've given up.
Yeah.
They came in and they say, this is the last chance. I've been to everybody, and their whole body tells me that they've fought the fight and they're done, and they're like 50, and they probably will live to be 85.
Well, I love the story you tell about the 80-year-old man on the walker who got rid of the walker.
Yeah.
You know, he's out playing golf again.
Yeah, he's fixing his rental property.
Yeah.
I mean, he's up on ladders. So that's we've strayed from autoimmune.
Yeah.
But I do have a patient that, oh my gosh, this is awesome. She was kind of unproductive, had to sit in a chair, couldn't enjoy her grandchildren, couldn't enjoy anything. And she had rheumatoid arthritis. Her hands were not functioning. Mm-hmm. And that's an autoimmune disorder. And hands progressively start moving to the side and getting all crinkled up. And
painful.
Crinkled is not a medical term.
But it's a good descriptor. We all know what it means.
It's people speak, because I'm speaking to people more than doctors nowadays. So her hands weren't functional, and she didn't feel good. She was in pain all the time. Yeah. And she, after the first 4 months, after her first pellet insertion, she had repainted the inside of her house. She said, I've been staring at those walls for 10 years.
Wow.
And I couldn't do anything about it. And so now I painted everything. And I didn't recognize her. She looked like a whole different person. I'm like, really? Is that you?
Well, but you know what? Pain makes you cranky. It makes you irritable. It makes you mean. It makes you miserable. And if you can do something to reduce the pain levels, then some of those people smile and laugh again, and it's safer to be around them. I mean, you can come in a room and they don't bite your head off.
Their families are all treated too. They're not through so much stress. I mean, all the good stuff kind of spreads out because families, grandchildren, children, all, don't feel like it's a chore to be around someone who is crabby and cranky. Not that it's not a good Christian or religious experience.
An obligatory family thing. We have to go see grandma. Oh, she's mean.
Yeah. But it's one of those things that you pray that you're not like that when you get older, and that other people don't see you that way.
Yes.
And so there is if you want a way out of that, there is a way to, in most cases, not be in so much pain if you have an autoimmune disorder.
Yes.
This is not in all cases of pain, but it's in autoimmune disorders, this does help.
Well, and you're very careful to say this is not a panacea. It's not a cure-all. It does make a difference for many, many people, and for a lot of those people for whom it makes a difference, they are eventually able to reduce or come off of other medicines and lose other diagnostic labels. But not all of them are. And so Kathy and her nurses are very committed to continuing to work with other physicians and refer you back to your regular doctors for the treatments that they prescribe, whether it's an antidepressant or an autoimmune shot or treatment or infusion. But those doctors are beginning to say, wait a minute, what's happening? like the doctor that said, I don't understand what's happening with the gal whose eyes are not deteriorating further. I don't know why that's happening, but he's able to acknowledge and recognize that it's happening and to say, because it's happening, we don't have to escalate your treatment. We don't have to go to this new medicine that we were prepared.
I was so excited that this patient had not progressed in her eye loss or her vision loss.
Yes.
And she was so excited because she lost 30 pounds. She lost
Secondary
30 pounds. I mean, she was excited about that, and her relationship with her husband was better. Those were her two biggies, and I was just like, oh, thank God, you can still see.
You can see.
Yeah. And so for me, that was my, the highlight of my week already.
And it is such a joy and a blessing when you are in the healing professions and the people with whom you work get better. And it's delightful to see. But again, it is science, it is medicine, there are ethical responsibilities, and one of the things that we want to say to you, we really want you to hear it carefully, we're not promising that this is a panacea that will cure all and fix all no matter what it is. What we're saying is that the quality of your life can be improved if you're suffering from these things, and that you should look into it, that you should discuss it with your physician, you should research it on the web, you should make your own decision. Be an informed consumer, talk to your doctor, consider this, and consider it in a timely fashion. That 10-year window for the replacement of testosterone is critical, and the 10-year window for the replacement of estrogen is critical.
Email your questions or comments to podcast@biobalancehealth.com. You can find the BioBalance Healthcast on iTunes and on YouTube. For more information about bioidentical hormone pellet therapy and other reverse aging solutions, visit biobalancehealth.com or call 314-993-0963. You can find Dr. Maupin on Twitter at Dr. Kathy Maupin and on Facebook at facebook.com/biobalancehealth. Find Brett Newcomb at brettnewcomb.com.